going to talk a bit about normal and abnormal EEG, and then Gabriel will talk about AEG. I think there's nothing else. Those are the two talks. On the seizure class. How many people were here for the morning session yesterday? For the classification? Not everybody. Okay, so I'll do the classification as well. Yes, yes. If there's time, then I'll do it at the end. Yeah? Okay. So, the neonatal period obviously is the first 28 days of life, but it is also the preterm period. So between 24 weeks gestational age to birth. And as you know, during that time, the brain develops rapidly. You have a very preterm baby to a term baby, and in the MRI, you can see how much the brain maturates during that time. And that is reflected by the EEG. So the EEG changes very rapidly during the preterm period, but also in the neonatal period. And then during childhood, it slows down. And therefore, really, it is quite important to know what kind of maturational changes you see and what is normal in a neonate, because that is very different what is normal in an older child. And this is sort of a summary of all the maturational changes appearing during the preterm period. I'm not sure how much you need to know, really, because we only include term babies, but I thought it would be helpful just for you to have an idea what you see. So just very briefly again, what we do in PREVENT is we do a polygraphy. So we have ECG, respiration, EMG, 2 EMG channels, and video. And we record 40 to 60 minutes is the minimum really you need for routine EEG. We will initially record always 4 hours, but then later when we do follow-ups, a couple of days later, we might record shorter. And the reason why we want to record at least an hour is so we capture wakefulness and sleep. And the montage, how many electrodes we use, so in older children, people use, or most departments use a full montage, which is 16 channels or even 21 channels. But obviously in babies, they have a smaller head and they are a bit more delicate, so you can't put so many electrodes on. And we use a reduced montage with 11 channels, and this is what we use. This is exactly the same what we used for the clinical trial I used to do, the NEMO trial. It's, I think, a good cover of the head. The prefrontal electrodes here, they don't pick up much information in neonates. So when we look at EEGs, then it's quite important to have in mind what the behavioral state of the baby is, whether the baby is asleep or awake or comatose and sedated. And then we look at the continuity, which means how continuous is the EEG. Are there periods of flatness, or is it continuous like this at all times? Whether it's symmetric between the two hemispheres, how high the voltage is, the amplitude, whether it changes between wakefulness and sleep or not. For example, the first sign in mild HIE is that the sleep-wake cycling disappears. So you have a baby which has no change in the EEG between wakefulness and sleep, which is abnormal. And then also whether the EEG responds to stimulation. And then you look for normal graph elements. Graph elements and features we see depending on the gestational age. And then obviously you look for any abnormality. So how does the EEG mature during the prenatal period? The most obvious sign of maturation is that an EEG goes from discontinuous to continuous. So in a very premature baby, the EEG is discontinuous. You have periods of flatness and then periods of activity. So here, the EEG is flat, and then there's a burst, and then it's flat again. And at very preterm babies, this, what we call the interburst intervals, so the periods of the flatness is the interburst interval, they can be up to 1 minute. And then these interburst intervals become shorter, so they go at 30 weeks, you should have 30 seconds, and then at near term, they are continuous. So at a near term baby, you should have a continuous EEG at all times. But also this sleep-wake cycling appears. So at around 30 weeks, you start seeing sleep-wake cycling, but not before. And at term baby, you have very clear sleep-wake cycling. The interburst intervals is really one of the most important things when you look at neonatal EEG. And to be honest, it's also the easiest to look at because it's so obvious. So look at this. It's so very flat. If you see this in an older child, this would be always abnormal, very abnormal. In a preterm baby, that's normal and not a problem. But you need to look at how long these interburst intervals are. And this gives you a rough idea what we would expect at a different gestational age. And a good rule is at 30 weeks, it should be no longer than 30 seconds. And then at about 35 to 36 weeks, it should be continuous in wakefulness and in active sleep at all times. But you can have very brief periods of discontinuity in quiet sleep. And at term, it should be continuous at all times. So here you see a baby at near term. So this baby is 35 weeks and it's continuous here, but the baby is now in quiet sleep. And here you have very brief periods of discontinuity. What is the difference between, when you can see there's some activity here, so is this continuous or discontinuous? And really the magic number in neonatal EEG is 25. 25 microvolts is what distinguishes continuous to discontinuous activity. Obviously, this is arbitrary. Who has set that number? But it's actually a very useful number, and everybody uses this number. So if an amplitude is less than 25, we call it discontinuous. If it's over 25, if you see activity in most channels over 25, it's continuous activity. And this is not only important for the evaluation of preterm EEG, it is also the differentiation between normal and abnormal EEGs in babies with HIE. So the first thing happens if you have a baby with HIE, the first sign of abnormality is a discontinuous pattern. So the EEG goes from continuous to discontinuous if you have an hypoxic event. So this is why this is so important to remember. And then, as I said earlier, you look for graph elements, different features in the EEG. Sorry? How do you measure the amplitude? So each EEG machine has very good. Let me find you an example. So what you have a measure here, and you can switch this on. You can switch this on when you look at the EEG. And so you say here, this is 50 microvolts. And then you take this here and measure it. And actually, in our machine, there is a really convenient measure. You just click on it and it tells you the amplitude in each channel. It's so easy to do. It's one of the best features I've seen on this machine. It's very easy and automatic, and you don't need to fiddle around. With the machine, the Exeltech machine we use, you have to click here, and it takes forever to measure only one channel. Your machine will tell you in one click the amplitude in all channels. So the graph elements, I'm not going to go into detail here, but you have, depending on what the gestational age, you have monorhythmic delta activity in the occipital regions, and then around 30 weeks you have premature temporal theta, sort of smooth temporal theta in the temporal regions. Then delta brushes also around 30 to 32 weeks. Delta brushes are sort of the hallmark of prematurity. You should not see much delta brushes a term, but sometimes you can see the occasional, like 1 or 2 per minute, but no more. So you have a slow wave with fast activity superimposed. This is your delta brush. And then multifocal spikes, frontal sharp transients, and frontal slow waves, which is also called anterior slow dysrhythmia. These 3 graph elements you see in term, so I'll show you another example of each of those. Multifocal spikes and sharp waves, I've said this yesterday already. This is quite important to remember. If you have an older child, for example, this is an 8-year-old child with epilepsy, and you do an interictal EEG, you see discharges here. Yeah, you see discharges over the right and the left centrotemporal region. And you don't need, you have a history of focal seizures at night, then you know this child has Rolandic epilepsy. You don't need to capture seizures. But in a baby, this doesn't work. So here is a 36-week-old baby with jerking, with a history of jerking, and you see sharp waves in the central region. This does not mean that the jerking is seizures. An interictal EEG cannot help you with the diagnosis of epilepsy or seizures. In a neonatal EEG, you need to capture the seizures. And that's because multifocal sharps and sharp spikes are a normal feature. They are a normal graph element, particularly if they occur in the central and temporal regions and are bilateral, but not necessarily synchronous. So you can see them on this side and then on this side, but you should see them at some point on either side. And then frontal sharp transients, you can see frontal sharp waves of the here, of the frontal region. It's a normal phenomena at term. It's not epileptiform. And then you see slow anterior dysrhythmia is slow waves over the frontal region. Again, if you would see this in an older patient, then you would see this is a focal abnormality, but in babies, it's normal. So I'll just very briefly show you some examples. This is a baby at 24 weeks, so you can see it's very flat. Here's the amplitude, and then you have a brief burst. There's not much else going on. And here you have the AEG, which is a discontinuous pattern. And then at 30 to 33 weeks, you have a more continuous pattern with only brief periods of discontinuity, lots of delta brushes, and some sleep-wake cycling already. Then at 34 to 37 weeks, this is a 36 weeks, so you saw earlier, mostly continuous, but maybe a couple of seconds of discontinuity during quiet sleep. And the normal graph elements I just mentioned. And then at term, you have, here's the AEG. What does this show? This is the sleep-wake cycling. Yeah, so a normal AEG, and here you have the EEG in wakefulness with a slow, with sharp transients and and slow waves, and a continuous EEG with mixed low amplitude activity. As I said, the sleep-wake cycling is an important feature, and what is interesting, when we go to sleep, we fall asleep, and then we go to stage 2, stage 3, stage 4, so into slow wave sleep, and then into REM sleep. But babies do it the other way around. They go from wakefulness to active sleep, which is the same as REM sleep, and then to quiet sleep. And this changes at around 3 months. So these are the different stages. In wakefulness, you have continuous activity, low amplitude, mixed activity. In active sleep, it looks more or less the same. So active sleep and wakefulness is more or less the same. And then in quiet sleep, you have tracé alternant, an alternating pattern, but it's not discontinuous. So high amplitude and low amplitude. Sometimes you already have high amplitude slow wave sleep. So here's an example of tracé alternant. This looks a bit like a discontinuous pattern, but here the amplitude is above 25 microvolts. And this just summarizes the 25 microvolt rule again, which is really important. So you have tracé alternant when all the activity is above 25. So you have low amplitude and high amplitude activity, but it's always above 25. And then in discontinuous pattern of preterm babies, it's low amplitude to high amplitude, but it varies with sleep-wake cycling and with external stimulation after the age of 30 weeks. And burst suppression pattern is also flat burst, but the bursts are always abnormal, like we saw in the baby yesterday. So now very briefly talking about what seizures look like. I've shown this yesterday already. So basically any rhythmic activity is suspicious, but you should see hopefully a sudden beginning and end. You have a focal onset and then a spread, an evolution or recruitment, and then with a change of amplitude, morphology, and frequency, and a minimum duration of 10 seconds. And you can have all sorts of different patterns. You can have sharp waves or spikes, delta or theta waves, alpha frequencies, beta, or even faster, a zip pattern. And I'll just show you some examples. So this one is the one I showed you. Here's the focal onset over the right. And then you have a change in amplitude and morphology and frequency, and this is the end. It's always over the right, it doesn't spread to the left. Here is another example, and the onset of the seizure is here, with slow waves, which become slightly slower and higher amplitude. You see an evolution of the discharge. And it's over the left hemisphere, yeah? And then it continues and becomes even slower until it stops. Sometimes there is very little sharp in it, but sometimes you see the discharges or the delta waves become sharper during the seizure. Or you can have faster frequencies which eventually slow down. And this is the zip-like pattern which I mentioned earlier. So you have a zip and then it's like opening a zip here and then it slows down. Again over the right temporal region with a tiny, tiny spread to the left. Very rarely you see an electrodecrement, so a flattening of the EEG. Much more common in older children, in infantile spasms, for example. That's a typical sign. In babies, that happens very rarely. And sometimes you see something which we call periodic discharges. So you have these discharges, but there is no clear evolution. There is no recruitment. They occur every 1 or 2 seconds, very periodically, throughout the whole of the EEG. So that's not a seizure, it's an interictal pattern. And periodic discharges you typically see in herpes simplex encephalitis or in babies with stroke. So if you see discharges like that which don't change, and the baby is not in status, then if they are on one hemisphere, then this could be stroke or herpes. Very rarely, or actually, what you can see in babies as well, if you look at this EEG, right is in red, blue is left. Can you see a seizure somewhere? Is it right or is it left? Any idea? Any thought? Just show blue or red. Red, okay. Very true. Here's a seizure, yeah? But if you look on the left, there's also a seizure. But it has a different frequency. And it has a different beginning and a different end. So you see a seizure here, also with an evolution. So sometimes you can see two seizures at the same time with a different beginning, a different end, and a different frequency in neonates. Burst suppression pattern is not an ictal pattern most of the time. This is very similar to the burst suppression pattern we saw yesterday in the baby with Otohara syndrome. This is also a child with Otohara syndrome. But rarely you have burst suppression pattern as an ictal pattern. So if you look at the deltoids here, you see that with each burst, this child had a myoclonic seizure. This is a child with paradox-independent seizures. And here, this is too short for a seizure. It looks like a seizure, but it's too short. And we call this a BIRD, a brief ictal or interictal rhythmic discharge. And these runs, they are not seizures, but they can give you an indication that this child is at a higher risk of seizures. So if you see shorter periods, then you should continue the EEG monitoring and see whether the baby might develop seizures. HIE, as I mentioned earlier, the EEG can be very helpful, and the first sign what you see is that you see that the EEG becomes discontinuous. So mild HIE, you still have continuous activity, but it's suppressed. If it's moderate HIE, it becomes discontinuous with interburst intervals up to 10 seconds. In severe HIE, up to a minute, and then an inactive EEG with inactive trace with no EEG activity or interburst intervals of more 1 minute is always very abnormal. So here is a normal EEG with sleep-wake cycling and continuous activity, normal features, and then moderately abnormal with brief periods of discontinuity, and the AEG becomes abnormal as well. Severely abnormal with flat, so interburst intervals of more than 20 to 30 seconds, or then completely flat. I leave the preterm things. I think artifact we did yesterday, so that's okay.